Hi everybody, welcome to CCO's module on integumentary system. I'm Joanne Sheehan and I will be doing the presentation today. Hi everybody, welcome to CCO's module on integumentary system. I'm Joanne Sheehan and I will be doing the presentation today. Hi everybody, welcome to CCO's module on integumentary system. I'm Joanne Sheehan and I will be doing the presentation today. Hi everybody, welcome to CCO's module on integumentary system. I'm Joanne Sheehan and I will be doing the presentation today. Hi everybody, welcome to CCO's module on integumentary system. I'm Joanne Sheehan and I will be doing the presentation today. Hi everybody, welcome to CCO's module on integumentary system. I'm Joanne Sheehan and I will be doing the presentation today. Hi everybody, welcome to CCO's module on integumentary system. I'm Joanne Sheehan and I will be doing the presentation today. Hi everybody, welcome to not contained herein, and CPT is a registered trademark of the American Medical Association. So today we're going to understand the key components of the skin, the nails, the breasts. We will define key terms. We'll try to understand the most common pathologies affecting the skin, the hair, the nails, and the breasts. We will understand procedures and surgeries that relate to the skin, hair, nails, and breasts. We will recognize common eponyms and acronyms for this section and identify when other sections of the CPT or ICD-10 should be accessed. Also, we will cover the HCPCS Level II codes and modifiers that are appropriate for integumentary. Now, the integumentary system is the largest organ system and includes the skin, the hair, and the nails. And when we code for any type of breast coding, whether it's a mastectomy or any disorder, it will fall under the integumentary system. And I love this diagram of this man where the skin has been removed and he's actually walking with it in his hand, so you can get a good visual of how much skin covers one human being. Now there are 3 layers of the skin. There is the epidermis, which is the top layer, and it is made up of 4 to 5 layers, and its only function is really protection. The dermis is the middle layer, and it has blood vessels, connective tissue, and nerves. And then we have the subcutaneous tissue, which is connective tissue and adipose tissue. And I'll explain this a little bit more in the next couple of slides. So here's the epidermis where the arrow is pointing, and this is made up of 4 to 5 layers, and the function is protection. So as you can see, that's the epidermis. The dermis is the mid layer right here where the arrow is pointing, and that contains blood vessels, connective tissues, nerves, and so forth. And then we have the subcutaneous tissue, but it's also referred to as the hypodermis, okay? And with the subcutaneous tissue, this is connective tissue and adipose tissue. So let me explain a little bit what this means. The connective tissue connects, supports, binds, or separates other tissues or organs, typically having relatively few cells embedded in an amorphous matrix, which is a gel-like substance, often with collagen or other fibers, and including cartilaginous, fatty, and elastic tissues. And adipose tissue or fat is an anatomical term for loose connective tissue to store energy in the form of fat, although it also cushions and insulates the body. Okay, so as you can see here, this is the subcutaneous tissue here, and we show how we have the fat, the connective tissue, and so forth. The subcutaneous tissue is not a layer of the skin. It lies just beneath the skin. And as I said, it is made up of connective and adipose tissue. But also part of the skin are the sebaceous glands, sweat glands, hair shafts, and blood vessels. And that is all part of the skin anatomy. And there are all types of CPT and diagnosis codes associated with them. Now, In ICD-10, when we're talking about the skin, there are 3 chapters that we will focus on. Chapter 2, which is neoplasms, and that's benign or malignant. Chapter 12, diseases of the skin and subcutaneous tissue. And then Chapter 19, injuries and poisoning. And we will also go through those in the future slides, but these are the main chapters that you would be dealing with. And here's a picture of the ICD-10-CM neoplasm table. And just to show you an example, if you look to the far left at the top, it says neoplasm index, and beneath that it says skin, not otherwise specified. And under there you see air, and then an indent where it says basal cell, specified type of squamous cell, and so forth. It goes to elbow, eyebrow, and when you hit eyebrow, it'll say, look at the skin and face, and then the eyelid, basal cell carcinoma, specified, or squamous cell. And then we have our columns. We have the malignant primary, the malignant secondary, cancer in situ, benign, uncertain behavior, unspecified behavior. The 3 that I want to focus on just quickly is the malignant primary, which would be obviously the primary reason for a visit and where the malignant neoplasm originated. The malignant secondary is when that primary metastasizes into a second place. When you code for neoplasm, if the doctor is treating you for where the cancer spread, the secondary malignancy, that will go on your first line for the diagnosis code. And then you would code the malignancy, the primary, beneath it. So in other words, if you had lung cancer as your primary and it spread to your breast and you went to see the doctor for breast cancer, you would be coding breast cancer first and using the malignant secondary diagnosis code, and then you would code the lung cancer because you're being treated today for the breast cancer and it metastasized from the lung cancer. And then cancer in situ is exactly how it sounds. It's in that spot, it hasn't spread. And benign obviously is the opposite of malignant, and then uncertain behavior and unspecified speaks for itself. But under skin you will find numerous categories, and you want to be sure that the categories that you pick align themselves with the CPT codes that you use when you are coding. Now, in Chapter 12, we talk about diseases of the skin and subcutaneous tissue. This can include skin infections such as bacterial and fungal, inflammatory conditions of the skin, and then other disorders of the skin, corns and calluses, keloid scars, keratosis, and other issues. So let's look at our first diagram. This one's not too bad. This is the infections of the skin, and the first column is bacterial, and some of the problems would be carbuncles and furuncles, cellulitis, impetigo, and folliculitis. And as you can see here, where I have impetigo highlighted, that is a picture of what impetigo would look like. Now on the right is the fungal infection, and many of us are familiar with athlete's foot, jock itch, ringworm, or yeast infections. This is an example of a ringworm. All right, so that's just to show you the difference, between bacterial and fungal. Now, the inflammatory conditions of the skin, we have dermatitis, erythema, and psoriasis. And I chose an example for each one, and I just chose one out of the categories. So the first one, dermatitis, seborrheic, atopic eczema, and contact. And this is a picture of atopic eczema on a child's face. And that's what it looks like. Contact dermatitis can come from laundry detergent or anything like that, or irritation from your clothing. Seborrheic is like little lesions on your back, almost look like little warts that seem to develop in older people over 50, a lot of times due to overexposure to the sun. The next picture is erythema, and we have an example here of rosacea. And then we have erythema multiforme and erythema nodosum. And this is, like I said, rosacea. And this is a very bad case. A lot of times it's just really in the cheeks, but here's an example of that. And psoriasis is and can be all over the human body. This is an example of the scalp, and if you look close enough, you can actually see some of it up here, but it has actually traveled outside the hairline and down onto the neck. So you will see codes for this as well, as you move forward. But it's nice to have an idea of what some of these look like. And the erythema is really redness, surrounding the area. Now, other diseases of skin and subcutaneous tissue, we could talk about corns and calluses, keloid scars, keratosis, diseases of the hair such as alopecia, diseases of the sweat glands, hidradenitis, of the sebaceous glands such as acne or skin ulcers. Now, the first picture I think is really interesting because this is a result of piercings on the ear as well as a tongue piercing. Pretty nasty, I think. And I can actually tell you that when my son was about 16, he decided to pierce the top of his ear until his parents found out and ripped it out. So, but no, we took it out nicely, and but he developed a keloid scar that was pretty bad behind his ear just because he went up to the top of his ear trying to put something in it. And he never had any type of experiences in the past with keloids, but he had to have it surgically removed. So they're pretty common with piercings. And here's a classic example, as you can see. As far as the diseases of the sweat glands, hidradenitis, this is also very common. You will see this in coding situations, not only with primary care physicians, dermatologists, but also with different surgeons. In fact, I know that in primary care, doctors will use Botox injections for the sweat glands if patients sweat profusely. But I also code for a cardiothoracic surgeon, and he actually removed sweat glands from a patient who suffered terribly from sweaty hands and whatever. So you can find these things and these type of diagnosis problems not only linked with the Botox, but also with the surgical procedure. So you want to be aware of that. And here's alopecia, which is just showing you loss of hair, which is pretty sad, but just to give you another visual. Now this one's terrible, so close your eyes if you can't handle it. This is what's called a pressure ulcer. It's a decubitus ulcer or a bed sore. And when you're coding for this, you need to identify the location of the ulcer as well as the stage of the ulcer. And stage 1 is just a persistent focal erythema. Stage 2 is partial thickness skin loss involving the epidermis, dermis, or both. Stage 3 is full thickness skin loss extending through the subcutaneous tissue. And in this example, it is necrosis or death of the soft tissue extending to the muscle, tendon, or bone. And I'm going to tell you that I have seen some of these pressure ulcers when I was a young girl and I was working as a unit secretary in a hospital, and I was on a cancer floor, and patients needed to be rotated all the time when they were there for extended periods. And even then, it was very difficult to treat. I've never seen one as bad as this, but I have seen them, and the nurses work very hard to avoid this. But this is an example of the worst possible case of a pressure ulcer, just to give you an idea. In fact, this was an example that I found from a medical book, and I cannot even identify what part of the body it is. I'm assuming it's the foot, but I don't even know. But it's a legitimate picture, just to tell you. Now, these aren't quite as bad. Injury and poisoning. This is the superficial injuries that we're all familiar with: abrasions, blisters, and contusions. And to the right, you will see a picture of what a contusion looks like. Open wounds are lacerations, bites, or puncture wounds. And in this case, I found a picture of a human bite. And that's pretty nasty, but that is an open wound. Okay, so again, depending on if it's just an office visit or if there's repair or whatever, at least you can visualize and see what that would look like. Now, burns. When you're coding burns, we need to know the site. We need to know the severity or the degree of the burn. And when you're coding from the ICD-10 CM manual, we need to figure out the total body surface area, which begins with the letter T, 3-1, and has additional character spaces. And you'll be able to see as we move forward how we do that. Now, there are 3 degrees of burns, and first degree is superficial, the epidermis only. And an example would be redness or tenderness. Second degree is partial thickness, epidermis and dermis, blister, or nerve endings exposed. And the third degree, epidermis, dermis, subcutaneous underlying tissue structures, and it requires immediate medical attention. And as you can see here, this is a first degree burn, a second degree burn, and a third degree burn. And I went into my medical manual to find some pictures to even help you more to understand. First degree burns, sometimes it's just a sunburn, like you can see in the right-hand picture. Other times it can be a burn such as the one on the left, which may have been someone going into a hot oven and touching the top of the oven, or having an iron fall on your hand and moving it away quickly. But that's basically just superficial, and that is considered a first degree burn. And I will tell you that when you're coding for Integumentary, it's one of my favorite things to code, but I am not going to lie. There are certain areas where my bubbling and highlighting notes in both ICD-10 and CPT are there for me. And I have been doing this longer than some of your age, okay? And I'm telling you that some parts of coding the skin are so involved. It's fun and a little challenging, and it can be done, but I highly recommend that you pay attention, understand first, second, third degrees, and to really understand the notes, especially in your CPT manual as we move forward, because it will hold your hand and tell you what order to code things and so forth, and what can and cannot be billed together, when to add a modifier 59, that sort of thing. So absolutely be sure you pay attention to your notes, that are provided for you, the guidelines. Now, second degree burns, again, from my medical manual, this is partial thickness, epidermis and dermis, blister, nerve endings exposed. And that's pretty nasty as well. And third degree burns is full thickness, epidermis, dermis, subcutaneous underlying structures, and requires immediate medical attention. And these are pretty horrific. I just can't even believe people, because I know this is one of the most painful type of injuries that a human being can sustain. Now, when we talk about total body surface area, I want to give you an example. A patient presented to the emergency department with third degree burns to the left lower leg, 4%. He also has a third degree burn on the right side of his chest, which makes up 8% total body surface area. Okay, but the patient also has second degree burns on his upper back and right shoulder, equaling 13.5%. So when you're coding for a burn, whether it's debridement of a burn or whatever is happening, you have to break it all down based on first, second, or third degree. You have to pay attention. Is it the arm, the leg, the back, the foot, genital area? I mean, you need to break it down, and the CPT manual shows you that. And so does the ICD-10 manual. So when you look at this, we see T24.332A, third degree of the left lower leg, and then the T21.31XA, third degree of the chest, and then T21.23XA, second degree burn on the back, T22.251A, second degree burn on the right shoulder. And then when you look, there are codes that will tell you the total body surface area. And what you are doing is you're adding the 4% plus the 13.5% to come up with a total. And the T31.20XA is the total body surface area. And it's all there for you and explained. So it really is not difficult. But the biggest thing is you want to make sure that you have the right parts of the body when you're coding. Now, when we talk about disorders of the breast, we talk about mammary dysplasia, which is category N60 in the ICD-10 manual. And signs and symptoms of mammary dysplasia include irregular lumps or cysts, breast swelling or discomfort, skin redness or thickening, and nipple discharge. And most benign breast conditions do not increase the risk of breast cancer, and it's also referred to as benign breast disease. In categories N61 to N64, all categories here point to disorders of the breast. And an example of that would be, say, a condition called ptosis, and that begins with a P, P-T-O-S-I-S. And to give you an example of this disorder, a family member of mine had a baby at a young age, and she was a very thin young woman, and she had, regular, decent sized breasts. And when she was in the hospital, she had chosen not to breastfeed, but under pressure with the nurses, she did, which was fine. And she decided on the second day that she wasn't going to do it. And when she was discharged, she was not taught how to release the milk from her breast after she went to the bottle. And what ultimately happened is her breast became engorged and really stretched out the skin and the tissue. It happened that a family member is a genetic component, and that a lot of the women in the family have run into what's called this ptosis. She had a 4th degree, which is like the worst you can get. It literally damaged all the tissue, skin, all the components of the breast, turned her breasts into pancake-like shape, and they fell almost to her navel. And it wasn't even a matter of cosmetics, because she had to tape herself, because even bras, nothing would hold her in. That's how poorly the skin condition was. I accompanied her because I work with physicians, and brought her to a plastic surgeon, 2 plastic surgeons that I know, for consults. And both of them had said that it was like she was a 64 instead of a 22-year-old woman who was 300 pounds and lost 200 pounds. That's how badly damaged her skin was. So she
Did anybody get sued in the process?
Did anybody? No. Well, no.
Malpractice there?
No, she didn't. But ultimately, what happened was the doctors, not only they cut the top of the breast to lift it, but because she had so much damage, and I'll tell you, it's my daughter, okay, my youngest daughter. She went through this, and they had to put anchors in her breasts, and they also had to put inserts in. And it was not for cosmetic reasons. It was just to make her normal. And now she's nervous to have another baby, because she's like, what's going to happen? It's most likely going to happen again. But it was terrible. She went to the Marine Corps ball, and I had to literally tape her up. That's how disfigured she became. So not to get onto this whole story, but these are the type of disorders that you may be coding for. And depending, for her, insurance did not cover this, even though there are CPT codes in the book and diagnosis codes in the book for this. And the procedure is called a mastopexy, but it is not typically it is not a covered service. So $12,000 later, she had this done. And it was just one of those things. And that's just one of many conditions that can happen to a male or a female's breast. Now, category N65 is deformity and disproportion of reconstructed breasts. And that typically, again, will happen. Let's say that if a woman has a double mastectomy and then has the breast reconstruction, which is a planned procedure after the mastectomy and is covered by insurance with a modifier 58, a lot of times what happens after the fact is that once the breasts have been reconstructed, they settle. And a lot of times as the breast falls, the nipple rises. So they have to be like readjusted and so forth. So these are really significant issues. And like I said, some of them would be covered. Like, for example, the reconstruction, breast deformity. Unfortunately, having deformity with giving birth, that's not covered. But you will find as you code and bill, what is covered and what's not. Now, most procedures that deal with the skin are covered for use in outpatient setting, meaning the office, or outpatient setting. But, anything typical like skin tags or, warts, anything like that are skin procedures that can be done in the office. However, there are procedures that are considered inpatient only, and some of them are the debridement of genitalia and perineum, or debridement of the abdominal wall, debridement of the external genitalia, perineum, and abdominal wall combined. There's a free muscle flap, microvascularization, the revision of the chest wall, and the extensive chest wall surgery. And again, these would not be performed in an office. This would be considered inpatient. So if you're coding and you're billing, you want to be aware of how these differentiate in an insurance carrier setting, simply because if you have an inpatient only procedure and you have an office location or an outpatient location, there will probably your claim will probably deny due to that conflict. So be aware of that. When we talk about incision and drainage, there are two types, simple and complicated. A lot of times students do get confused about this, and the simple is just really putting in, an incision and incising and just draining something simply. But a complicated incision and drainage is the placement of a drain or gauze strip packing, presence of infection, hemorrhaging requiring ligation, and an extensive amount of time is used. And in order to not be confused, just read what the doctor writes and see how complicated it is, because simple is just what it is, very simple. But if he is indicating that he has placed a drain somewhere or a gauze strip packing or so forth, then you would focus on complicated as the code to use in a procedure or even the diagnosis. Now, debridement. This is a method for removing dead tissue, dirt, or debris from infected skin, burn, or wound, and it is based on the percent of body surface area. Debridement of necrotizing soft tissue, and remember, necrotize means dead, death, so it's the death of soft tissue, and it's based on the area of body being debrided. The codes for debridement that are inpatient only range from 11004 through 11008, and then we have the medicine category in the back of your CPT manual. That's 97597 through 97610. Now, when we go to the top where it says method for removing dead tissue, dirt, or debris from an infected skin, burn, or wound, I'm going to clarify this a little bit more, because you can bill for debridement for dirt and debris without it being infected. Now, when my husband, who was a bicyclist, was on a road and drove on his bicycle and a car came too close, he fell off his bike and went elbow first into the back window of an SUV and tore his left arm to shreds. He tried to fix it at home, and unfortunately, it wasn't going to happen. And I witnessed firsthand a debridement of dirt and debris under skin, ripped skin from a bad accident. And he had, I can't remember how many stitches, but it was not infected. It was a wound, and it was but it was an immediate wound. So you may have to code something which is a debridement that is not an infected skin, burn, or wound. And as long as your diagnosis codes tell the whole story of what happened and so forth, and you have all your external cause codes and everything like that, and location of where an accident took place, telling the story on a claim, then you would be able to get paid for that. Okay? And on the 97597 to 97610, I find in podiatry that the debridement code 97597 is used from time to time, not a popular code that pays with insurance companies, but it is out there, and one that I see podiatrists use all the time. And the picture on the right is showing you the debridement of infected dead tissue or whatever, removing all that soft tissue. And it is very painful even when it's anesthetized. Paring and cutting is exactly as it states. It's hyperkeratotic lesions, otherwise known as corns and calluses. And this coding is based on the number of lesions removed, and an example would be removal of 3 corns, 11056, 2 to 4 lesions, and removal of 8 corns, which is 11057, more than 4 lesions. Okay, so if you code 2 to 4, it would be 11056 and 11057 if it's more than 4. There's also a code 11055 for 1 lesion, but it seems that in most cases the 11056 is the most popular. These 2 codes are used in podiatry quite a bit, and I will tell you that if anyone is billing as well as coding, I highly recommend that you go into your Medicare administrative contractor, such as Palmetto, NHIC, NGS, wherever, Meridian, and get the local coverage determination for these codes. There are not only specific modifiers that are required, there are also specific diagnosis codes that will pay this. These fall under the category, just like other codes I'll be showing you, that are considered routine and not routine foot care, and you need to be sure that you follow the guidelines exactly when you use these codes. So because most insurances follow the guidelines of Medicare in this area, I would suggest to supplement what you're learning here and from the course and really understand what these 2 codes involve. Now, when we talk about biopsies, if there's a biopsy of a single lesion, all we're going to use is 11100 for a single lesion. If there are any additional lesions that are being removed, you will see the code beneath it in the CPT manual with a plus sign, which means add-on code, and that means each separate additional lesion. So as an example, if the patient comes in and has 3 lesions removed, you would code first lesion 11100, and then each separate additional lesion is 11101. Students get confused with this, and I'm telling you now, make sure you remember this, because if you have not taken your CPC exam, there will be some reference to coding with these type of scenarios where instead of listing 11101 on 2 lines, you have to put ×2. So in other words, if there were 5 lesions, you would do 11100, and then you would do 11101 × 4. So 4 units and 1 unit equals 5 lesions. So people get confused. I'm not saying that you might run into something with a payer down the road that says, no, we want it listed separately. 99% of the payers want it this way. And if you're sitting for the exam, you have to know it this way. Deal with the billing end of it if you go that route down the road, okay? But this is what you need to remember. And this is one of my loves. I love coding integumentary, but I always have to remember this because I get myself confused, and it's really not that difficult, but I'll second guess, but I always reference my CPT manual, and it helps me along. So really, like I said, pay attention to the guidelines in your CPT manual. Obtaining tissue during another procedure is not considered a separate biopsy. So if a doctor goes in to remove a lobe of a lung and decides to do a biopsy while he's in there, you would be billing and coding for the lobectomy, but you would not bill for the biopsy that took place in the lung. Okay, so that's just an example. So be aware of that. Some procedures actually will have the words including biopsy or with or without biopsy, so you want to pay attention to the words as well. But if it's just in the documentation that they did this procedure and did a biopsy, you cannot bill or code for the biopsy. The removal of skin tags. So 11200 means that you can use this code whether you remove 1 skin tag or 15. Okay, now 11201 is an add-on code, and if you read the words, for each additional 10 lesions or part thereof, which means that the doctor may have removed 15 lesions and 2 additional, and so you would add the 11201 to include those 2 additional lesions because it's part of the 10 lesions that they're giving you. Now, if the doctor removed 35 lesions, you would code 11200 for the first 15. Then you would do 11201 times 2 to equal 20 lesions. And 20 lesions plus 15 lesions is 35 lesions. So hopefully you understand that. Okay, and the shaving of epidural lesions, 11300 to 11313. This includes local anesthesia and chemical electrocauterization of the wound. And these codes are always based on the size and the anatomic location. And I know when you go to the Batcave and you're bubbling and highlighting, you will see how you underline the locations and the sizes right down the page, because it's very important. You don't want to be coding an arm when it's a leg. Okay, so and it's pretty self-explanatory. Excisions of lesions. You want to focus on the measurements, the lesion diameter plus the narrowest margins. If you open your CPT manual to page 75, you will see illustrations of measuring lesions. And you will it will be broken down into benign and malignant. The size will be in centimeters, and it will also have it broken down by anatomical location. Now, just a couple of tips. Benign obviously means it's non-cancerous. Malignant means it is cancerous. A lot of doctors have a tendency to give you their excision of lesions before the pathology report comes back. And it really should be given to the coder once the pathology report comes back, because number one, the codes are different, both CPT and ICD-10, but also the reimbursement is a lot more for a malignant excision opposed to a benign. And that's really important. Centimeters, I have to have a visual. This is another area where I find it easy to code, but I can't in my mind just run off and say like, oh, 2 centimeters is this. So I have a table that's actually on my laptop and my PC that converts centimeters to inches. And the reason is that I once had a neurosurgeon who coded craniotomy or something in the skull. And he had down something like 400 or 40 centimeters. I don't know what it was. And I remember asking my husband, who's a doctor, and he knows how, all this stuff off the top of his head. I said, how big is that? Is that right? And he said, no, it's about the size of his body. He put in too many zeros. And so from that point on, I said, doctors can make mistakes too. So I always either label my CPT manual, or I used to. Now I just have a table that I'll look at on my computer screen. But if you're one of those that really wants to understand the size of any of the lesions, then when you see the descriptions in your CPT manual, you could almost add like equals approximately 2 inches or 4 inches and that type of thing. And again, focusing on the anatomical location, very, very important, especially if your diagnosis says one thing and your procedure is another. You have a lot of options there. Now, when we talk about nails, which are part of the integumentary, we talk about fingernails and or toenails. We talk about trimming or debridement. 11719, trimming of nails not defective. 11720, debridement of 1 to 5 nails, and 11721, debridement of 6 or more nails. And on page 78 in your code book, you can see the illustrations for the nail. It's an anatomy of the nail. These are also codes that are used by doctors, but primarily I see them with podiatry. And these codes will also be listed in that local coverage determination that I just mentioned, because trimming nails that are not defective may not get paid. They may be considered routine foot care. However, if the patient cannot walk or has circulation problems that affect their feet and their toes, that is definitely, there are definitely diagnosis codes that will go with that, as well as modifiers telling the insurance company the type of problem and category that these fall under. So it is important for you to research this further, and that would include the fingernails as well. But you want to be absolutely sure you understand these, because if routine care is not covered. Typically, non-routine care is. So you want to make sure. A lot of times these codes are associated with people that have peripheral vascular disease, peripheral diabetic neuropathy, you know, things like that, different complications from diabetes.
Time for a question?
Sure.
For the inpatient-only codes, wouldn't we code the PCS code?
No. And that is for the inpatient-only codes, that's, it actually can go either way. Well, the thing is, doctors that are Part B physician billing, they can do these procedures in an inpatient location, and that's what they're referencing. The PCS is actually the procedure code for that's ICD-10 PCS. So these are CPT codes for procedures. So this is strictly physician billing, but it would have to take place in an inpatient setting. So they would not accept it in an outpatient setting or an office visit. So in other words, there are some procedures even that can be done, say a sigmoidoscopy can be done in an office or an outpatient setting, but you wouldn't go in and have a coronary artery bypass graft done in an outpatient setting. That has to be done in the hospital. It's the same thing. Maybe not as extreme as a bypass surgery, but it is definitely just physician. PCS are the procedure codes, volume 3 of the ICD-10 manual, and those are procedure codes, and that's what you would use if you were coding inpatient for that.
Great. That's it.
Okay. All right, so now when we talk about pilonidal cyst, I was kinder to you and gave a very mild picture, but there are 3 types of pilonidal cysts. One of them is simple, which is just excised and sutured. Then we have extensive, which is larger than 2 centimeters with an extensive excision enclosure, and complicated, which is very extensive, which requires reconstructive surgery. Now, if you remember the picture of the decubitus ulcer, the pressure ulcer, where the skin was pretty much eaten to the bone. Well, I saw some pictures of the complicated pilonidal cyst, and I figured I would be kind and not show you another gruesome picture. But they can be pretty nasty if left to fester and require reconstructive surgery. So here in this picture, we just have a diagram where there is a cyst, and this is the dimple right here where they repair. Now, the codes in the CPT manual 11900 to 11983, it's referred to as introduction. Intralesional injections, tattooing, tissue expansion, contraceptive capsule, insertion removal, hormone implantation, and drug delivery implants. And so it's basically the introduction, the first step into something that's going to be done. A lot of times tattooing is done when there's going to be some type of radiation therapy. This is an example of the tissue expansion after a mastectomy, where they'll put these expanders in implants, you know, preparing and working towards reconstruction. And this is what a woman that has lost a breast due to mastectomy, and that falls under the introduction tissue expansion codes. I do want to stress here that when you are dealing with these 119 codes and you're dealing with the breast or any of these injections, especially with the breast, pay attention to the descriptions on the CPT codes, because some of them are unilateral, and in parentheses, you want to pay attention to those parentheses, because it may tell you use modifier 50 if it's bilateral, but some procedures may actually include the word bilateral, so you do not need modifier 50. There's a lot of information that involved in this particular section, especially with the breasts. So I really can stress this. I can't stress this enough because you will get questions about this. And as I've said in almost all my webinars, when it comes to testing for your CPC or your CPB, it's guidelines, guidelines, guidelines. That's all I can tell you. All the questions will point to the guidelines, so that the questions may seem obvious, but if you're not reading the guidelines and you're not reading the parentheses and all of that information, you're going to get your answer wrong, because they really need you to understand how it works or the exceptions to the rule. Okay, so that's just a little tip there. Now, again, when we talk about repair, there are 3 factors to consider: the length of the wound in centimeters, the complexity of the repair, and the site of the wound. And this is an area, again, where students get very confused. Wound closure always includes either sutures, staples, or tissue adhesive. Wound repair using only adhesive strips, you report with an E&M code. All right, so in other words, if the doctor, you have a laceration and the doctor is just going to use adhesive strips, clean it out, and give you adhesive strips, it may just be either an emergency room code, like, was it 99282, or maybe in the office a 99212, something like that. However, if it's intermediate or complex, then we have to pay more attention, to the descriptions of those, which we'll get to. Medicare does allow the use of HCPCS Level II code G0168 for wound closure with tissue adhesive. However, it is not recognized under the outpatient prospective payment system. So you may want to make note of that in the guidelines for this section. A simple repair is a superficial wound, 1-layer closure, and sometimes will include, local anesthesia. Intermediate elements of simple repair plus layered closure of deeper layers of the subcutaneous tissue. Here I want to stress, because this may also come up in an exam, and it's a note in the guidelines: simple. If a patient has a simple wound but has extensive debridement, such as the example I gave you of my husband going through a window, and there's extensive debridement done before they close the wound, even though it's not deep, that simple closure can turn into an intermediate repair because of the extensive debridement. So you want to make sure that the example that's given to you in the exam describes exactly the type of repair. And if they're saying that it was extensive debridement, read the guidelines and highlight it, because that simple moves right up to an intermediate, and it's right there in black and white in the guidelines. Complex. Complicated wound closure includes debridement, stents, and is always more than a layered closure. But in your CPT manual, there are excellent definitions of the simple, intermediate, and complex, and learn them, underline them, because the exam is open book, so you can reference them if you get confused. When you code wound repair, the wound should be measured and recorded by centimeters, and the lengths of the wounds are added together by complexity and anatomic classification. So what does that mean? If you have 2 wounds that are intermediate repair on, say, your leg, and they're both the same depth, you measure that it's the same depth, you measure the width. So if the doctor says this one side of the leg, it's 10 centimeters, and this part of the leg is 2 centimeters, you add those together to find the code. But if one is the arm and one is the leg, you have to find the anatomic location and code accordingly. But if it's added together, they're added together by the complexity and the anatomic classification. And some of the components of wound repair are the ligation of small vessels, exploration of surrounding tissue, nerves, and tendons, and normal debridement. And if extensive debridement is required, you would use 11042 to 11047. And again, all this information is in the guidelines in your integumentary section. So if you reference page 79 of your CPT book, when more than one classification of wounds is repaired, list the more complicated as the primary procedure and the less complicated as the secondary procedure using modifier 59. So it really does tell you, it does help you in terms of how to code. But it is an organ system that I constantly, 36 plus years doing this, I still reference my guidelines for integumentary. I am not quick with Mohs surgery. Even though I code it right, I'm slow at it because I need to be absolutely sure I'm following the steps. The same with wound repair or excision of lesions. I want to be absolutely sure I'm doing it right. I just don't wing it. Like maybe someone else in CCO, another team member might, but for me, I take my time with that. So maybe this will come easy for you, but if not, don't despair, because everything is spelled out for you in the guidelines and you will be fine. So just practice a lot so that you won't be overwhelmed if it shows up on a test. Now here I have a question. Sure.
If a physician states excision of lesion D, do we assume it is a neoplasm? We used to be told unless they say neoplasm, you couldn't assume. Has this changed?
Unless it says neoplasm, you cannot code it as a neoplasm, because a lot of times doctors refer to actinic keratosis or seborrheic keratosis or even warts as lesions. So that even if it says D, no, definitely I would not use it neoplasm as a diagnosis, benign diagnosis. Is that what she's asking? Okay.
Yep.
Yeah. I know sometimes it gets tricky, but fortunately the CPC exam doesn't have ambiguous type situations, so they're very specific, and most everything is open book, and you can find the answers in the guidelines in your manual, so you're okay. When we talk about repair of the adjacent tissue transfer or rearrangement, this is another one that I always reference because I need to look at the illustrations. I need to understand. I have to visualize it. And on page 82, there are illustrations, so that will help you. Some of the examples of tissue transfers and so forth are Z-plasty, W-plasty, V, Y-plasty, rotation flaps, and advancement flaps. And to the left, as you can see, this is a Z-plasty. And it's pretty obvious just by looking at the picture that this repair, and plasty means repair, is shaped like the letter Z. See, so that will help you. And the same goes for the W or the VY. And then to the right here, we have a rotation flap, and it's a semicircle skin flap. And it starts with, a lesion on the face, and then it's all inked out here, and it's opened up, and pretty much all the skin is moved and rotated around to cover the lesion. And this is the ultimate ending. I mean, it's amazing what surgeries can do. But again, this is one that you will have questions about adjacent tissue transfer and rearrangement. There are very specific guidelines in the book, and I would practice these as well. I mean, it may be just one question, but it may be time consuming, and you want to be able to fully understand it. Not difficult, but you need to understand it. I don't do enough. I can guarantee you that if I did integumentary all the time like I used to, I used to be able to code it just like that. Now it's once in a blue moon that I get to do it. So it's something that I always pull out my guidelines for. When we talk about the skin replacement surgeries, there are different types. We have the free skin grafts, which are completely freed from the donor site. Pinch graft, which is small split thickness repair. And then there are codes, the 15002 through 15005, which is based on the size of the repair as well as the site. 15271 to 15278, the application of the skin substitute grafts by location measured in square centimeters. Again, I have my tables because I need to have a visual when they describe it in an op report. 15050 is pinch graft measured in centimeters, not square centimeters. And square centimeters calculation is length in centimeters times width in centimeters equals square centimeters. So again, these are my little notes that I write all over my CPT. To understand the different grafts, we have autograft, which is from the patient's body, the allograft from the human donor, the xenografts taken from different species, such as a pig, tissue cultured epidermal autograft grown from patient's own skin cells, skin substitute grafts, substitutes for skin, and that can be a homograft, an allograft, or a xenograft. And if you need visuals for these, honestly, Google them and look at the pictures if you need to have a visual. You may not want to, but I'm just saying that if it's something that you have a hard time with in this particular section, definitely get some visuals and describe them like in the guidelines so that you understand. Repair flaps, the 15570 to 15738. It can either be skin or deep tissue. It's based on the type and the location, and codes do not include extensive immobilizing device enclosure. So you want to read over the flaps and make sure you understand those as well. There are other flaps and graft codes, the 15740 to 15777. free muscle, free skin, facial or hair transplants. 15756, 15758 can only be used in an inpatient setting. And again, it's physician, Part B, physician billing, using an inpatient location to do the operation. They can do pre-op and post-op in their doctor's office. These are not PCS codes, okay? So that would be done in the inpatient. Also be aware that even though these codes are in CPT, depending on the diagnosis, they may or may not be paid by an insurance carrier. If it's considered cosmetic in any way, you can be rest assured that it's not going to pay. So you want to make sure that the operative report gives a complete story and that you understand. Some of these other procedures that are repairs, which may or may not be paid for as well by insurance, is dermabrasion, chemical peels, which is chemical applied to the skin and removed, cervicalplasty, removal of excess skin from the neck, blepharoplasty, removal of excess skin from the upper eyelid, and rhytidectomy, excision of excess skin elsewhere on the body. And honestly, depending on your situation will depend on whether or not these type of procedures will get paid. If you're stuck on terminology as well, I've said this before, I've used blepharoplasty all the time as an example. When you come to your CPC exam and you don't know what a word means, look it up. Look up blepharoplasty. And it's going to say it's the repair of what, you know, and when you look it up, it's saying it's removal of excess skin from the upper eyelid. So you know that the body part is the upper eyelid. These words, if you can't remember, you know, cervical meaning neck, then when you read it, it's removal of excess skin from the neck. And plasty, we know, means repair. If you don't remember that the word ectomy is excision or plasty is repair, then go to the front of your CPT manual, and those suffixes are actually in the front of your book, and they're listed so that that will help you remember what they are. But you know, they may not pay for a blepharoplasty, but if the condition is bad enough that it's affecting someone's vision, then it would be paid. Excess skin from the neck, I'm not sure, or other parts of the body. If you've had a bariatric surgery and you've lost a lot of weight and have excess skin, it may fall under a staged procedure like reconstruction of a breast. I have never coded for that. I have heard two sides where they do and they don't. It may be decided by the payer, but I just want you to be aware that, you know, these codes exist and there are CPT codes for them, but it does not necessarily mean that they will pay, particularly if the insurance claim form and the diagnosis used is showing more of a cosmetic nature opposed to medical necessity. So always remember that, okay? Oh, I thought I already went over this, but I guess I didn't. This is what I was talking about when we talked about the pressure ulcers and the decubitus ulcer bed sore, or talking about necrosis of the tissue down to the bone, the death of the tissue. This is very serious. It's deep tissue, fascia, muscle, or bone that's affected. And with ostectomy means removal of the bone under the ulcer, and it's based on the location, the type of ulcer, and the extent of the closure. So if you remember when we went over the ulcers, there were the 4 stages. This is by far a stage 4, as you can see. It's significant. When I worked as a young girl, a young mom, I worked nights at a hospital on a cancer floor, and I saw all the time how the patients were constantly rotated to avoid these decubitus ulcers. And some patients still developed them because they were in the hospital for so long. So, you know, but depending on what stage, if the doctor just writes pressure ulcer, you need to understand what stage it is, because you need to be as specific as possible, not only with the repair, but also the diagnosis codes that fall into place. And this is a classic example of a stage 4 pressure ulcer. So when we talk about repairs and we're talking about burns, local treatment, there is called a Lund-Browder diagram and classification method table that shows burn estimates and the calculation of the total body surface area. And the treatment involves dressing changes and debridement based on the size of the area, which can be small, medium, or large. If you go to your CPT manual and turn to page 90, you will actually see a picture of the human body, and it's all broken up like with little broken lines, giving you the diagrams of the total body surface area to help you. And I actually use that diagram even when I'm coding for my diagnosis codes. So make a note in the diagnosis section where it's the total body surface area, reflect what page in your CPT manual so that you can cross-reference, because you really have to make sure that your T codes, I think it's T31 codes for the total body surface area of the burn, matches up with the CPT codes, okay? And you will see that diagram on page 90. We're getting towards the end here where we talk about the burns, the local treatment. It's continued, and that's the escherotomy, and that's cutting through dead skin, covering the surface of full thickness burn to promote healing. And these are inpatient codes. 16035 is for the initial incision, and then we have add-on codes 16036 for each additional incision. And again, if there are 3 additional incisions, it would be 16036 times 3. So it would appear as 16035, 16036 times 3 equaling 4 incisions. So I'm pretty sure that that is it. Oh, no, I'm not. We're still going. Okay. I thought we went on. Destruction, ablation by any method other than excision. That's electrosurgery, cryosurgery, laser treatment, chemical treatment. A lot of times you'll see this associated with actinic keratosis, seborrheic keratosis, plantar warts, things like that. Benign, pre-malignant based on the number of lesions. And you want to code the malignant lesion according to the location and size in centimeters. And again, malignant lesions do bring in more money, but it's not even the money as much as it's the accuracy in coding according to the pathology report. So if our doctors hand us coding that says that they've excised a lesion, we hold them aside until we can match up the pathology report with that particular procedure. So we are actually coding properly. Otherwise, everything would be benign because there is no definitive diagnosis. Oh, I forgot about Mohs. Micrographic surgery. This surgery was developed by a Dr. Frederick Mohs in the 1930s, and it's really used primarily for basal cell carcinoma and squamous cell carcinoma. I can just about guarantee that you'll have a question on Mohs somewhere on your exam. And it's like, I'm not telling you there is, but my guess is there's a good chance because Mohs is a very common type of a testing question. It's also a very involved surgery that you have to understand the guidelines and read everything, underline everything, and fully understand it. When I do a Mohs surgery, I always get my answer right, but they can take me 15, 20 minutes because I'm slow with Mohs. So practice this one if you haven't sat for your exam, okay? Just get a real feel and understanding of it. It's not that complicated, but there are numerous steps that need to be taken, and it's all there in your CPT manual. So when we talk about Mohs, it's the removal of a complex or ill-defined skin cancer. It's the physician acts as both the surgeon and the pathologist, removes it and puts it into blocks. And you need to know what all these terms mean. You know, they remove them in blocks, they put them into containers and so forth. So they remove the tumor tissue and perform a histopathologic exam. And they may have to repair the site based on the extensiveness of the skin cancer. So you may also be reporting the repair of the site separately. So your question may be very simple, but if it is pointing towards a repair of the site and that it's an extensive surgery, then know that you can do both. But even though it's here on the slide and it's telling you this, definitely it's all explained, but I just recommend that you practice a few times so that when you see the question, you know exactly where to go, what to look for. Because when I practiced it before my CPC many years ago, and I also practiced it for my CPB, I had it down. But it's, again, something, if you don't do it all the time, you're a little slower, and you need to you know, look at the guidelines, and the guidelines are wonderful, so do not ignore them. Okay, the breast, the various types of you know, CPT codes associated with the breast are incisions, excisions, the introduction, which is the pre-op needle localization wire, repair, reconstruction, biopsy, percutaneous or incisional. And in this case, I'm showing you an example of a mastectomy, unilateral, and then the breast reconstructed after the mastectomy. And when you code for the reconstruction, you use modifier 58 because it is a planned procedure after the removal of the breast. So always remember that. The mastectomy, muscles and lymph nodes involved will determine the code selection, and you need to understand the difference between the radical, you know, mastectomy and so forth. And it's an inpatient only. The radical includes pectoral muscles and axillary lymph nodes. The 19306 is radical, including pectoral muscles, axillary, and internal memory lymph nodes. So read the wording if you have this on your exam. And again, make sure you read the parentheses, because there are notations concerning the mastectomy in your CPT manual, and most likely something will point to it, whether it has to do with a bilateral procedure or something else. So pay attention to that. The repair, reconstruction are the codes used after the reconstruction, you know, after the mastectomy. And then the mastopexy, which I discussed about the breast lift, again, depending, it may or may not be paid. My guess is that most often it is not paid, but again, there is a CPT code for it. And then we have the reduction mammoplasty, which is a breast reduction. And again, there's certain criteria that needs to be met for a breast reduction. So you want to be sure you understand that when you read the op note and the guidelines to make sure that you're coding properly. The photodynamic therapy, the 96567 and 96571, here's a picture of a pre-treatment, 1 week post-treatment, and a 1 month post-treatment. Quite a difference in facial. And this is an example of one of the ways that you would receive photodynamic therapy. I've seen it where it's a handheld piece of equipment as well, but it seemed like the majority of the pictures showed instrumentation such as this. And again, if this is strictly cosmetic, most likely it would not be paid. Special dermatological procedures, actinotherapy, photochemotherapy, and laser treatment. So these are all under the medicine section, which is in the back of the book. These codes begin with the number 9, just like your E&M codes. And a lot of times new students get confused and they're looking for their office visit and hospital visit codes in the back of the book with the medicine section because they begin with 9. E&M is at the front of the CPT manual. Medicine section is at the back. And these are the codes that are under the medical medicine section. Okay, this is the last page. Now I remember. There are some HCPCS Level II codes that are involved with Integumentary as well. The one that I'm very familiar with is the G0127. This is the trimming of dystrophic nails, any number, used with Medicare patients. And again, reference this HCPCS code in your local coverage determination if you want additional information. If there are any questions pointing to this in your exam, it will not be extensive because this is not a billing exam. This is a coding exam, and you just need to know what's considered routine and non-routine and things like that. The G0168 is the wound closure utilizing tissue adhesives only. The G0295 is electromagnetic therapy to one or more areas for wound care other than described in G0329 or for other uses. And then down below, the G0329 electromagnetic therapy to one or more areas for chronic stages, up to stage 4 pressure ulcers, arterial ulcers, diabetic ulcers, and venous stasis ulcers, not demonstrating measurable signs of healing after 30 days of conventional care as part of a therapy plan of care. These are HCPCS Level II codes. These are Medicare codes. A lot of Medicaid plans will accept them, and I know of certain local carriers in the Boston area that accept them. But from the terms of coding, these HCPCS Level IIs typically just for Medicare. And that is pretty much it for Integumentary. There is, like I said, a lot. It's one of my favorites, but it is definitely, there is a lot of information when it comes to the skin. Not complicated, because if you bubble and highlight as you're taught through the Blitz, you will not have any problems. And if you practice your exams, you'll definitely not have any problems, because the more you do it and the more you practice, the faster you'll go through them. And the Mohs surgery can take time, as well as calculating the excisions of malignant lesions, understanding how to do the widths and the margins. I mean, really, without my book open and a calculator, I am no good, and I get it. So I'm just telling you, practice, and I think you'll be great. Okay. And that is the end of Integumentary. And I thank you for joining me. And I just want to make sure there are no more questions.
Yeah, I got one.
I can answer. Okay, I hope I can answer it.
Going back to debridement.
Yes.
The question was, would you bill the debridement in addition to the intermediate wound repair in that example of the extensive debridement?
No, just it would fall under intermediate. I remember asking this question at a seminar, and I was told no. It would just strictly, the intermediate repair is a completely different level with higher relative value units, which incorporates the debridement in it. So if it's a simple debridement, you would just build that. But if it's more, then you would use just the intermediate. But I'll double check on that, because I know I attended a seminar through Medicare not long ago, and I had someone ask that question, and that's what I was told. But in coding, we know, and in billing, the rules change on a daily basis. So if there's any change, I certainly will post it, and you just tell me where to post it, Boyd, so that everyone will know. But from what I was told, you would not be billing the debridement, you would just be billing the intermediate. But I can look in the coding guidelines as well, which I don't have, and it will tell you there as well what to do.
Got it. That's the only question we had, and we had a really good turnout today. So thank you, everybody, for joining us.
Thank you for joining us.
Thanks, Joanne.
Okay, see you next week. Bye-bye.
Take care, everybody.
Okay, bye.